Welcome everyone. We're really excited to have everyone here for our Adult MDS Chapter event brought to you by the HealthTree Community for MDS. My name is Mary Arnett. I'm our HealthTree for MDS Programs Manager, and I am so grateful to have all of you here for our meeting today and for your support in building up our MDS community. I would like to let you know that our session today is going to be recorded, and the recording along with the slides today and any resources that are shared are going to be sent via email to all of the event registrants within 48 hours of the event concluding. Let's see. So today we're going to start with a brief Zoom meeting tutorial for anyone who's not familiar with the platform. We would love for you to have your camera on and to keep your cameras on if you feel comfortable. We believe that doing that kind of helps us to build a community, being able to see each other face to face. You can see on the slide how to turn your camera on. At the bottom of the screen, you should see the microphone and the camera buttons. You can click the video icon that says to start video in order to turn the camera on. But with that being said, if you aren't comfortable having your camera on or being recorded, you are definitely not required to do that. Your microphone should currently be off, and we'll ask that that be kept off until the end of the presentation when we have our discussion session. If you have any questions or comments for us or for our speaker throughout the presentation, you can click on the chat icon and type those comments or questions in the chat. If you're using a mobile device or a tablet, you can click the three-dot icon that says more and then chat, and that will let you access the chat box to type in those questions. Lastly, if you would prefer to verbally ask your question during that discussion part of the event, we highly encourage you to do so. If you're on a laptop or a desktop computer, you can click the reactions near the bottom of your screen and then click to raise your hand. If you're using a mobile device or a tablet, you can click the three horizontal dots that say more and then click the raise hand button, and we will make sure that everyone who raises their hand gets to ask their questions. So now we're going to get started with today's event. First, I'd like to thank our sponsors who make events like this possible, Bristol Myers Squibb and AbbVie. The topic of our event today, I am very excited, is MDS cancer navigating your MDS diagnosis? Here is our agenda for today. I am going to introduce our speaker, Dr. David Swoboda, and then he will spend the next 30 minutes or so giving us his presentation on this topic. After the presentation, we're going to open it up for questions and comments. So I want to take a second to introduce our speaker, Dr. David Swoboda. Dr. Swoboda is a member of the Hematologic Malignancies Program at Tampa General Hospital Cancer Institute and assistant professor at the University of South Florida College of Medicine. He's actively involved in the care of patients with acute leukemias and myelodysplastic syndromes, in addition to serving as principal investigator on multiple clinical trials in these diseases. He has presented his work at numerous national conferences and has several first author publications in top-tier journals, including Leukemia and American Journal of Hematology. I'm sure you can see with his impressive resume why we are so excited to have him as our presenter today. So with that, I am going to go ahead and turn the presentation over to him and let him answer the question, is MDS cancer?
Perfect. Let me get my slides up. Okay. Thank you so much, Mary, for the wonderful introduction, and HealthTree for inviting me to give this talk on a topic that, I'm really excited to speak about. This is my passion, myelodysplastic syndrome, acute leukemias. This is what I do my both clinical, spend all my clinical time on, and also do all my research in. So it's a really great topic, and I think this particular question is something that comes up a lot. And so, yeah, is myelodysplastic syndrome cancer? We get this question a lot in clinic from patients, family members, even other physicians, on whether or not when they get the diagnosis of myelodysplastic syndrome, are they dealing with a cancerous disorder, or are they dealing with something that is considered precancerous? And I'll go into more detail of what I think about this topic in the next few slides. But before I specifically broach the question, I want to, touch on, what myelodysplastic syndrome actually is. And so when I think about myelodysplastic syndrome, it starts in the bone marrow. The bone marrow is our factory of our blood cells. It basically produces our white blood cells. Our white blood cells fight infections. Our red blood cells provide oxygen to our body, and our platelets, which help with clotting. And what happens with myelodysplastic syndrome is there's normally a genetic or chromosomal change that occurs that leads to dysfunction or dysplasia in these cells. And it leads to overall low blood counts. And generally, patients present with symptoms or features related to these low blood counts. However, most patients are actually found incidentally, routine blood work, checked by a primary care office showing decreased red blood cells most often. In MDS, when you have dysfunctional cells, they're often large. So you can have what's called a macrocytosis or a large red blood cell. But this can be found incidentally. Patients are asymptomatic, and these patients we often observe. Well, when patients do have symptoms, what they generally present with is fatigue due to the low red blood cells and lack of circulating oxygen in their body. They can also have bruising or bleeding related to low platelet counts, again, what helps with coagulation of our blood. Or they can have infections related to low white blood cell count. And particularly, we are most concerned about neutrophils, which are our main type of white blood cell that fight bacterial infections, but also are very important in fungal infections and viral infections. And so we don't really know exactly we don't have a very specific direct cause of MDS, but we do know a lot of things that lead to MDS. And so we see about 30 to 40,000 new cases of MDS diagnosed each year in the United States, but this number is actually low compared to the amount of MDS that is probably present. And that's due to the fact that a lot of patients have, low blood counts, otherwise asymptomatic, and might not get a bone marrow biopsy to make the diagnosis. But the average age is around 70 to 75. And the most important factor that we know of that leads to this syndrome is DNA damage. And that DNA damage in most cases is from aging. So basically over time you have dividing cells in the bone marrow. And as someone ages, they have less of an ability to regulate the damage that occurs in their cells. And so these dividing cells occur over time. Eventually, what happens is a genetic mistake occurs. Normally, your immune system would clear out this genetic mistake, but sometimes because of certain factors, you're not able to actually do this. And that damaged or atypical or dysplastic cell, in this case, ultimately leads to a frank disorder. We know that MDS is more common in males at about a 2-to-1 ratio. We know that occupational exposures can increase patients' risk of myelodysplastic syndrome. And rarely we do see that it is something that is passed down from one generation to another, where patients have what's called a germline mutation or an inherited mutation in their blood that they then inherit from a parent, and either have a congenital bone marrow failure type syndrome or just a defect in DNA repair that ultimately leads to this dysfunctional disorder, normally at an earlier age in these cases. So let's go into what actually cancer is. So if you ask a lot of different providers, you're going to get a lot of different answers. If you Google what is cancer, every website will have a slightly different explanation. But I think there's sort of important themes that sort of define what cancer is. And so I'll talk about those themes, and then I'll talk about why MDS potentially matches those themes. And so cancer is when abnormal cells divide in an uncontrolled way. So like I said, we generally see abnormal cells. It's generally a single population of cells rather than a lot of different types of cells that has a genetic mistake that occurs, and then it proliferates. And so if it's a abnormal breast cancer cell, it will proliferate and cause a breast cancer. If it's an abnormal prostate cancer cell, it'll do the same. And it grows and divides in an uncontrolled way and then leads to the cancer that we know. Cancer also has the potential to spread. And so in stage 1 disease, it's localized cancer, but the cancer always has the ability to go through the lymph nodes or lymphatic system, which is sort of our white blood cell circulating system, or through the blood to spread to other sites and metastasize. And cancer also is driven by genetic changes. So it's generally a genetic change that turns a bunch of different cell types to one specific cell type that then grows in an uncontrolled way over time. So what's the difference between cancer cells and our normal cells? So our normal cells grow and divide, but eventually, like humans, as they age, they will die through a process called apoptosis. Cancer cells have the ability to ignore the signals that that normally would cause this apoptosis or cell death process, and ultimately leads to increased of these abnormal cells, in an area or in circulation. Cancer also has the ability to hide from the immune system. So our immune system is sort of our checks and balances on cancer. It doesn't only work on infection. It also works on our cancer and kind of keeps the cancer in check, doesn't allow it to grow. And when it does come up, it potentially goes in and kills the cancer. But cancer, it has the unique ability to hide from our immune system. So it can basically create a wall or turn down our immune system that then it doesn't allow to do its normal killing. In oncology, we've actually been able to, across different disease subtypes, we've been able to utilize the immune system to actually target cancer. So we have many therapies that are able to either ramp up the immune system or engineer the immune system and give it back to a patient to then ultimately target and kill their cancer. The other thing that we know about that's unique about cancer is it has chromosomal losses or chromosomal gains. So in a normal cell, you have 46 chromosomes, 22, and then an X and a Y or an X and an X if you're a female. But in a cancer, you can have a loss of a chromosome or a gain of a chromosome, and that's what ultimately leads to disease. And so why is MDS then a cancer? So MDS has abnormal cells. So these are these dysfunctional looking cells that we see, the dysplasia that we see in myelodysplastic syndrome. So here on you see a normal neutrophil. It has, 3 to 4 lobes. It has normal spots, which we call granulation. But if you look to the right, there's dysfunctional looking cells. They lack these spots. They have an abnormal or unusual looking nucleus, which is the kind of purple area here. You also can have it the dysfunction in the red blood cells. And so you have a normal immature red blood cell here on the left again, and then you have abnormal cells. So they can have multiple nuclei. They can be very large again, leading to the macrocytic anemia that I discussed. And then you can also have dysfunction of the platelet factories, causing platelets to be low. And so you can see multiple nuclei, large cells with single nuclei. And basically what happens is you get these dysfunctional cells. They don't work well. They get destroyed easily in the peripheral blood, and you just don't have a lot of normal cells circulating around, so leads to the low blood counts. So we have abnormal cells that are then dividing in an uncontrolled way. So in a bone marrow, we have a certain amount of cells that we expect. And so what we generally say is that you take your age and you subtract it from 100. So let's say you're 70. You would subtract 70 from 100, and we expect your bone marrow to be about 30% cellularity. So this is a bone marrow, the pink and purple being sort of the cells, the white being the fat. And this is sort of a normal distribution of fat to cell ratio compared to the MDS bone marrow on the right, which shows an extremely hypocellular packed marrow that has an uncontrolled amount of dysplastic cells. We rarely do see some patients that have low numbers of cells, but they are very dysfunctional cells nonetheless. cancer has the ability to spread, and so does MDS. And so MDS is not only localized in the bone marrow, it actually spreads through the blood. And so, when you look under the microscope, you can see these dysfunctional cells in the blood. So this is a dysplastic neutrophil. It lacks those spots again. These are other dysplastic looking neutrophils here. And this is actually a leukemia cell. So, we again think about MDS a lot of times as this a less aggressive type disorder, but in the reality, it comes from a very low risk disease to a very high risk disease, very similar to an acute leukemia. And so patients with myelodysplastic syndrome can have leukemia cells, which are basically immature white blood cells that are stuck in the most immature state. So you really go from a stem cell to a very immature white blood cell, and then you mature to a normal neutrophil or monocyte or other sort of infection fighting cells. But the more leukemia cells or blasts that you have in a myelodysplastic syndrome predicts overall, in most cases, a worse prognosis. And so this is a circulating leukemia cell that could be found in what we would likely think of a higher risk myelodysplastic syndrome patient. So what about the genetics of MDS? So like all cancers, and particularly MDS, where we're learning a lot about genetics, it is related to genetic changes, most of which that occur over time. And so when you look at this figure, that it shows some of the more common mutations. So the most common being the largest circle, the less common mutations that we see being the smaller circles. And so mutations like SF3B1, TET2, ASXL1, TP53 are sort of our more common mutations that we see that drive this disorder. And mutations are extremely important in MDS, and as well as a lot of other cancers, because they predict diagnosis. So, for example, SF3B1 mutant MDS has a very specific way that those patients present in most cases. And we have a diagnostic category that they fall under. It predicts prognosis, where patients with SF3B1 mutations have a good prognosis, whereas other patients with some of these other mutations tend to have a worse prognosis. And it ultimately also affects treatment. So certain treatments patients do better with certain mutations, and certain treatments they do worse. And so, genetic changes are also very important in this disorder. And chromosomal changes are equally as important. MDS is probably one of the best defined disorders where we know the most about chromosomal changes. And so again, what you're seeing here in this figure, 22, what should be 22 normal chromosomes, each with 2, and then an X and an X here. And so, this is the 5th chromosome. And so what we're seeing here is a loss of part of the 5th chromosome. This leads to what's called del5q, which is a specific subset of myelodysplastic syndrome. Here we see a gain in a chromosome in the 22 region. And this is what's called karyotyping. So this is what physicians look at to look at the chromosomal of the makeup of the disease, one of the things that we look at. But again, important in diagnosis, we have patients that have 5q, which is its own separate syndrome. Important with prognosis, depending on if you have, let's say, an 11q, you can have a very good prognosis. If you have complex, like this patient, where you have a lot of chromosomal change, it's a very poor prognosis. And then also treatment. 5q patients tend to respond really well to a pill-based therapy that we use that I'll talk a little bit about later. So that's really discussing sort of, some of the molecular and genetic changes that occur in myelodysplastic syndrome. So I wanted to touch on, what does the workup for this cancer look like? So what if you go into an office, what is your expectation for what is going to be done? And so generally you would present with low blood counts. You would be referred from a primary care doctor or an oncologist to a doctor like me, and we would notice that the blood counts are low. We would go through a pretty detailed history because we want to know, is there other medications? Is there, exposures? Is there viral infections that could decrease the blood counts? We would do a host of labs. We're going to want to rule out things that potentially could cause low blood counts. We want to get the CBC, which is your complete blood count. That has the white blood cell, the red blood cell, and platelet count. The lower the blood counts are, the more tendency to be higher risk disease, although not always the case. We want to rule out some other things like B12 folate deficiency that can cause similar presentation. And then importantly, if there is suspicion and concern, we do what's called a bone marrow biopsy. And so that is a procedure where, you basically, get local or, sedation. And ultimately, they take a small amount of the actual bone marrow itself out, as well as some of the fluid out of that space. And we look at under the microscope, similar to what some of the slides that I showed you previously, and we can see the dysfunctional cells. We can see the increased amount of cells. We can potentially see leukemia cells in that area. And we do molecular testing, and molecular testing can be done in the peripheral blood, but is most sensitive on the bone marrow itself. And it allows us to get that genetic information that we need to make all the decisions about the next steps. And so how do we determine prognosis for this cancer? And so we have a scoring system. So when we think about myelodysplastic syndrome, it's not a stage 1, 2, 3, 4 type scenario, because it's really circulating in your blood. It's in your bone marrow. It's more of a risk type equation. And so I talked about some of the things that were included in the risk, but I'll kind of go over it again. So chromosomal changes can be anywhere from very good to very poor risk. You can have bone marrow blast proportion. This is the leukemia cells that can go from low to very high. If you're above 20%, that would be consistent with an acute myeloid leukemia here. But MDS patients can be above 5% and less than 20% and still be considered MDS with excess blasts. You have the lower the hemoglobin gets factored in, the lower the platelet count gets factored in, the lower the neutrophil count, the bacterial fighting cells get factored in, and we basically come up with the score. And based on that score, we have a general sense of what the survival is to look like in a MDS patient. And this is called the International Prognostic Scoring System. This is the revised or somewhat newer version of that. And so we use this as a tool in clinic in context with obviously a lot of other things to help talk to our patients about prognosis. But can we take this one step further? And so that has been done by now incorporating genetics in. So this is the IPSS-M, so the M for molecular. And there was a presentation in the New England Journal of Medicine, and basically what was found is that in patients that are untreated mostly, we can better define risk categories. And in this case, they had very low, moderately high, and very high risk categories. And we know that a very high risk patient has about a twofold increased risk compared to an average MDS patient. A very low has a twofold, decreased risk compared to an average MDS patient. And so what about treatment for MDS? I'm not going to go into, extreme detail here. We could have a whole talk or multiple talks about treatment for MDS, but just highlighting some of the really big points of treatment for this cancer and sort of what it looks like. And so it's really dependent on the risk of a patient as well as their goals of treatment. And so oftentimes, especially in lower risk patients, we are focused on quality of life. We are focused on symptom improvement. We try to have blood count improvement, but I think it's really symptom improvement, quality of life is the most important things, as much as we worry about delaying progression or even survival for that matter in this particular case. So if a patient comes in and they have, blood counts that we are not too low, are otherwise asymptomatic, we're going to recommend observation for these patients. We likely will watch their blood counts a little bit close for the first couple months to kind of get an understanding of the pace of disease. And then we'll often space out the labs to every 3 months, sometimes every 6 months, especially if patients have a lot of factors molecularly cytogenetic that seem to be consistent with a very low risk disease. Another treatment modality for MDS is transfusions. So sometimes patients need red blood cell transfusions. Sometimes they need platelets transfusions to really support their blood counts and keep them, feeling okay. The next class of drugs is red blood cell stimulating agents or maturing agents. And so there's really two types of drugs in this class. It's the erythropoietin stimulating agents, or ESAs. This is erythropoietin alpha, which is Procrit or Retacrit generally, or darbepoetin, which is Aranesp. These are subcutaneous injection. The goal of these drugs is basically like, if you think about it, it's exogenous hormone, so it's like testosterone, but you're giving someone instead, erythropoietin, which is normally produced by their kidney to help stimulate the red blood cells. And so we give it under the skin in a subcutaneous fashion, either weekly, every other week, or every 3 weeks, depending on which formulation that we're using. And we monitor patients' blood counts closely with that. We also have a drug named luspatercept or Reblozyl. And that is another red blood cell maturing agent. It just had a really great presentation at the American Society of Clinical Oncology conference, where it showed that it might be better than ESAs in the frontline setting. Right now, it's approved in the second line setting, but it's another way that we can specifically work to mature red blood cells and ultimately improve red blood count count that leads to symptom improvement and hopefully for a patient's quality of life improvement. Other agents that we use are lenalidomide or Revlimid. This is a pill-based agent that we can use in that 5q syndrome. That was really where it was FDA approved, but we also use this in patients without the del5q chromosomal change. We have a drug called ATG, which also is another drug that affects the immune system. We tend to use this in hypoplastic or low cellularity MDS. And then these agents down here, we start to think about when we're getting to either refractory low risk MDS or higher risk MDS. And these are our hypomethylating agents. So this is basically a low dose type of chemotherapy that we give. It is either azacitidine or Vidaza. This can be given IV or sub-Q. There's decitabine that is also an IV formulation. And now in higher risk disease, we even have an oral formulation. But the goal of these are basically to give low dose chemo that actually sort of allows differentiation or sort of normalization of the cells, the different cell types, and potentially increase of the blood count over time. They also are good in high risk disease to potentially decrease the leukemia cells in certain patients. And then the final thing that I'll discuss is allogeneic stem cell transplant. So in our high risk patients, and that are otherwise fit and healthy to go to a transplant, we generally recommend a transplant because it is our only way that we cure high risk disease. And so just the basics of what a transplant is we basically take the stem cells of a donor. Those are the most kind of immature cells, basically before the blast that would produce the red blood cells, produce the white blood cells, produce the platelets. And we take those stem cells out of a donor. That can be a family member or an unrelated donor. We ultimately use chemo to clear the patient's own cells out of their system. And then we give these donor stem cells basically through what's like a blood transfusion to the patient. And we allow those normal cells to come back over time with the hope that that kind of replacement of cells will help lead to a cure in these patients. It's something that we, rarely have to do in MDS, but in higher risk patients, we generally try to do. And the final thing that I'll mention, because I'm a clinical investigator, and it's my passion to do clinical trials. And really, none of these agents would be, approved without clinical trials. Is that clinical trials are extremely important in all cancer subtypes, but definitely in MDS. We lack a lot of good drugs in the higher risk patient population that can't go to transplant. So if there is clinical trials available, a lot of them being standard of care plus something else, definitely think about enrolling in a clinical trial, not only for your own situation, but also for the growth of the field over time, if it's, feasible, obviously. And so I'm going to work back to the question of, is MDS cancer? And so hopefully I walked you through why, I believe, and most in the, leukemia field believe that yes, MDS is truly a cancer. MDS has abnormal cells, dysplastic cells, leukemia cells, or blasts that grow in an uncontrolled way. MDS can spread, through your blood. Rarely it can form, a tumor, but it definitely can spread through the blood. And then it has genetic and chromosomal changes that drive the disease, similar to, other cancers. And so because of that, actually in the recent World Health Organization classification for myeloid disorders, they actually proposed that we should consider calling this myelodysplastic neoplasms, basically, bone marrow dysfunctional cancer, rather than a disorder, to reflect the fact that, we all believe that this truly is a cancer and not a pre-malignant state. And so that will be something that I think you will hear, and so we'll sort of catch on over time. And so I'll end there and turn it over to any questions that anyone has.
As a reminder, if you have any questions, we can put those in the chat and we can ask them. Or if you want to ask it verbally, you can raise your hand and then we will call on you and you can unmute yourself and you can ask the questions that way. So it looks like we have one question from Katie that says, can you talk some more about clinical trials you're currently working on that seem the most promising?
Yeah, so I'll talk a little bit about clinical trials in general, and then clinical trials that I'm specifically working on. So in general, I think like I said, it was two of the main trials that the MDS community is most excited about was presented at, one of our major meetings a few months ago. And one of them is the luspatercept versus ESA clinical trial, basically showing that luspatercept has a transfusion independence rate at 8 weeks that's double of what we're basically able to see in patients that are receiving ESAs. So everyone is really excited about luspatercept coming into the frontline setting. I think that likely will lead to an FDA approval. The other trial that was presented was another phase 3 clinical trial, and we don't get a lot of phase 3 clinical trials in MDS, so we were really excited about it. But this is imetelstat. It's a telomere inhibitor, and basically what that trial showed was in second or third line setting, in patients that are heavily transfusion dependent compared to placebo, there was also a significant improvement in transfusion independence rate and potentially some disease modification. Both of these trials were in lower risk disease, but were extremely exciting for the MDS community. More challenging has been trials in higher risk disease MDS. We've had a lot of what look like very exciting agents in the phase 1, phase 2 clinical trial setting that have then gone to phase 3, and for whatever reason not had as much efficacy in a randomized fashion. So things that I'm currently doing and others are doing, some of the would be thinking about treating some of these higher risk patients more similar to what we do in AML actually. And so we have a drug called venetoclax that we utilize in acute myeloid leukemia for elderly or unfit patients. And so there's a lot of good data now being generated for venetoclax, a BCL2 inhibitor, in myelodysplastic syndrome. And you do generally require lower doses, but ultimately seeing high response rates, ability to get patients to transplants. And because of this, there's second and third generation BCL2 inhibitors similar to venetoclax, and one of which we're participating in a clinical trial for, that are sort of coming in the pipeline. The other thing is that, the immune system. And so again, we talked a little bit about it, but we use the immune system in all cancers and try to ramp it up to help kill cancer. But the challenge is that in myeloid disorders, most of our ability to utilize the immune system for one reason or another hasn't really worked as well as, let's say melanoma or lung cancer or some of the other solid tumor or even lymphomas for that matter. But we do have sort of new ways that we're thinking about utilizing the immune system. Generally, most traditional ways were through T cells, which is a viral fighting cell. But now we're thinking about, macrophage-based therapies, NK, which is another type immune cell-based therapies, and TGH, among others, is working on bringing on a lot of these new type of immune-based therapies in, our leukemia program, but also, in other, malignant heme programs as well.
It looked like Jimena had a question.
Yeah, thank you. Okay, so why do you think there is this misconception that MDS, it's not cancer? Like, is it from the general population or also from other physicians?
Yeah, I think because there's such a broad spectrum of MDS, sometimes people will get diagnosed, with a very low risk MDS, and, it will not affect their life expectancy at all. And so people tend to kind of think about that and bundle it in with a non-cancerous process. And so I think, and that's a good thing. We have a lot of patients that have MDS that live a very long time or are minimally affected by the disease. So I think that might be also blood cancers in general tend to be kind of confusing for most patients and even physicians to understand, because it's not something that we see. It's very easy to understand a breast cancer. It's very easy to understand a prostate cancer because it's something that you see. It's an organ you sort of have the ability to understand. When we talk about the blood, it's a little bit harder when we talk about all these different very unique types of blood cells and dysfunction of the blood cells. It kind of gets a little bit more challenging to perceive and really understand. And I think that's another reason that sometimes it sort of gets lumped in with non-cancerous conditions. But yeah, there's a lot of other blood cancers outside of MDS. Like you can have what's called chronic lymphocytic leukemia, right? It has leukemia in the name, but it's another syndrome where, a lot of those patients go untreated for an extremely long time, might not need treatment at all. It fits very similar to, the kind of how we think about, MDS. But really no one thinks that is not a cancerous condition. So I think it's a little bit of just the naming of it, and a little bit of just perception of it, and just kind of the complexity of thinking about it, is what's led to that.
Thank you.
While we wait for some other questions to come in from the chat, I wondered if you might be able to comment a little bit on the mcgrawmab trial halt. I know that was something everyone was really looking forward to in the MDS community. If you have any insights on that at all, any thoughts?
Yeah, mcgrawmab, what Mary's mentioning is one of the macrophage inhibitors that most physicians in the MDS community were very excited about. It had shown sort of good outcomes in high risk MDS, in TP53 wild type, so patients that lacked a TP53 mutation, as well as TP53 mutant disease, which tends to be a very high risk subset, very resistant. And we saw sort of high response rates, potentially durable responses. But this is the challenge, is that sometimes when we do phase 1 and phase 2 trials, we select the ideal population for the clinical trial, and then we sort of expand it into the real world, and you start bringing on more patients. And sometimes that it becomes a little bit more challenging, or just the complexity of the patients makes the ability for that drug or to work better. I would say with mcgrawmab and really all drugs, there generally is a population that still will benefit, right? It's just whether or not we selected a population in that clinical trial to be the one that's most likely to benefit from this drug. And so I don't think we can say, right, I know the halt is going to deter a lot of people in MDS for macrophage-based drugs, but there's still ongoing trials in AML, although they're on pause as well right now as data reviews. There's still other ways that we're targeting the immune system, and there's plenty of case scenarios for us having one drug class where we had several trials that failed in that space, and then we found the right target, or we found something that's slightly different, and that drug was ultimately, or even running the trial slightly different, and that drug was then successful, led to an FDA approval, and was then able to be utilized. But yeah, it's been challenging to, we haven't had a positive phase 3 clinical trial in MDS in a very long time, in high risk MDS in a very long time. And so that's something that we're obviously, as investigators, trying to figure out a way to get through that. Hopefully venetoclax might be one sort of drug that can do that, but we'll see.
Thank you. We have a question. Michelle asks, what are my chances of getting MDS if my father has it?
It's a good question. So, like I said, the majority of patients that have MDS, it is accumulation over time, right? It is, a genetic mistakes that occur through aging alone. So, I would say if, a relative was, elderly, it's likely that their MDS came from, just a genetic DNA damage over time. Is if that relative is a young individual, then we start thinking and questioning that could this potentially be genetic related, especially if that individual has not only just myelodysplastic syndrome, but either other physical features that are concerning for a bone marrow failure type 2 syndrome, or they have other cancers. So we start to think about it when people have multiple cancers that we might need to do genetic screening. We do know that there is some mutations, MDS-based mutations, that present with MDS later in life. Should all patients that have a relative with MDS get genetic screening? The answer is probably no in most cases. But I think it's very situational. I don't think it hurts to talk to a genetic counselor. We have genetic counselors at TGH that can sort of go through the family tree, cancer risk, and really have a good discussion about not only like should we test, but what are the implications if we do test, and figure out if it makes sense in each particular case. But again, the majority of MDS and acute leukemias are not inherited. They are acquired through DNA damage over time.
Thank you. I just had one more question. Can you talk a little bit about the benefits of, or I guess the importance of seeing a specialist or having a specialist on your care team if you're being seen in a community clinic?
Yeah, so I would say, the challenge with cancer and MDS in general is that, it's becoming more complex, particularly the complexities related to the decisions that we make based on the molecular makeup of someone's individual MDS. So, generally, I recommend, that all patients at least have, one visit with a doctor that takes care of, MDS or leukemias, so we can ensure that the appropriate testing was done, that they have, an NGS that was performed, so that we have all the information we need to make the appropriate, prognostic decisions and discussions. And then ultimately, to potentially help guide treatment options and really try, my goal is to focus treatment on that individual patient, and the individual molecular makeup, chromosomal makeup, of their individual disease, in addition to, factors like age, functional status, what patients value in life. And so bring that all together. And so it's not really a one size fits all type treatment, especially with genetics now, it's very individualized. And so, I would recommend that most patients at least have one visit. I don't necessarily need to, follow all the time. At an academic center, there's a lot of very, very good community providers that are very comfortable taking care of MDS. And the majority of my patients, get their therapy in the community, see community doctors a lot more than they see me. But I'm generally there to help, explain the disease, help explain the mutations, and then make sort of like the little nitty gritty, challenging decisions that can arise in an MDS case over time when it's needed.
Hey, thank you so much for your presentation today, for sharing with us, for helping answer that question of is MDS cancer, and kind of helping us understand where that complexity can come from, and ultimately answering the question that yes, it is, and for answering any of the questions today.
But thank you so much, Mary, and everyone else at HealthTree, MDS, for inviting me to give this talk. It was really fun to make these slides and give this presentation. And I put my Twitter there. If anyone wants to reach out to me, feel free, and I'm more than willing to answer any other questions in the future.
Thank you so much. So that is all the time we have today. I'd like to take a quick second to mention our next upcoming meetings are going to be on September 22nd and on October 3rd. On September 22nd, we're going to be talking about the decision of treating or not treating low-risk MDS. And I'm really excited about this conversation and to learn a little bit more about some of the complexities that come with low-risk MDS. And then on October 3rd, we're going to be hearing from an MDS specialist who is a researcher on anemia, telling us more about what anemia is and what any patient with MDS should know about anemia. If you have any questions about any of these events, you can find them on our MDS website at www.healthtree.org/MDS-community-events. It's a little bit of a mouthful there. Or you can visit our MDS site, which is just healthtree.org/MDS. There's an events drop down. You can click into that, and then all of our MDS events will be there. The event recording, as well as the slides that Dr. Swoboda shared with us, are going to be sent out to anyone who registered for this event within the next 48 hours. And then they will also be posted on our website so they can be viewed there for any family members or friends that you think would benefit from hearing this information. Again, we want to take a quick moment to thank our HealthTree for MDS community sponsors, without whom this event would not have been possible. So that is Bristol Myers Squibb and AbbVie. And finally, just wanted to say thank you to everyone who attended this event today, for helping us to build this MDS community. I hope each of you have a great rest of your day. Please don't hesitate to reach out to me if you have any questions about any of our upcoming events or any of our other HealthTree programs. Thank you so much. We're so glad to have you here and hope to see you on September 22nd.